Yeah, we can start now.
Yes. Good morning, everyone. I'll be talking about neovascular glaucoma today. Neovascular glaucoma, it is a severe type of secondary angle closure glaucoma, and there is anterior segment neovascularization present, fibrovascular membrane on the surface of iris, pupillary margin, and trabecular meshwork can be seen. It can be associated with and or secondary to retinal ischemia. Certain disorders predisposing to the neovascularization of the iris and angle include systemic vascular diseases, ocular vascular diseases, other ocular diseases, intraocular tumors, and others. So systemic vascular diseases, most common is the carotid occlusive disease, then carotid artery ligation, carotid cavernous fistula, giant cell arteritis, Takayasu disease. Ocular vascular diseases include diabetic retinopathy, central retinal vein occlusion, central retinal artery occlusion, branch retinal vein occlusion, sickle cell retinopathy, Coats disease, Eales disease, retinopathy of prematurity, persistent fetal vasculature, syphilitic vasculitis, anterior segment ischemia. Other ocular diseases include chronic uveitis, chronic retinal detachment, endophthalmitis, Stickler syndrome, retinoschisis, pseudoexfoliation syndrome, and intraocular tumors like uveal melanoma, metastatic carcinoma, retinoblastoma, lymphoma, reticulum cell sarcoma, and ocular therapy like radiation therapy and trauma. So, coming to the epidemiology, 36% of all the cases of neovascular glaucoma arise from CRVO, 32% from proliferative diabetic retinopathy, and 13% from the carotid artery occlusive diseases. The pathophysiology behind neovascular glaucoma is because of ischemic retinal tissue, which causes secretion of angiogenic factors, mainly VEGF, which diffuse into the anterior segment, anterior chamber, and cause iris and angle neovascularization. The clinical features seen in neovascular glaucoma include neovascularization of the iris, angle, and anterior chamber. There is elevation of intraocular pressure, and peripheral anterior syncytial formation is seen. It is also associated with ocular pain, decreased vision, ectropy on UVA, anterior chamber inflammation, cupping of the optic nerve, microcystic corneal edema, conjunctival hyperemia, and retinal disease with ischemia, inflammation, or tumor. So, how to differentiate between the new vessels and the dilated stromal vessels? So, neovascularization, it is usually present in fine tufts at pupillary margin. They are irregular in size. There is irregular pores, branching can be seen, and they are located on the surface. The dilated stromal vessels are delicate, lacy, and have uniform size. There is radial course. They do not adhere to the normal anterior segment vasculature, and in the angles, they cross the ciliary body face and scleral spur as fine single vessels that branch as they reach the trabecular meshwork. So grossly, there are three stages of neovascular glaucoma. Stage 1 is rubeosus iridis, where IOP is normal. Neovascularization of iris is seen with or without neovascularization of the angles. Vascular tufts are seen as at the pupillary margin. Stage 2 is the open angle glaucoma stage, where IOP is elevated and there is increased NVI and NVA. No synovial angle closure is seen in this stage. In the third stage, where there is angle closure glaucoma, the IOP is increased, visual acuity is reduced, and synovial angle closure formation happens. So, theories behind this vascularization. It is said that because of the retinal hypoxia, angiogenic factors like vascular endothelial growth factors are secreted in the anterior segment, anterior chamber. As VEGF is the primary source, it is secreted from the molar cell. It is a potent angiogenic stimulator promoting proliferation, migration, proteolytic activity, and capillary tube formation. Vasoinhibitory factors, these are secreted from the vitreous and the lens. Coming to the clinicopathological course, there is pre-rubeosis stage, then comes the pre-glaucoma stage where there is rubeosis iridis formation, then is open angle stage, and then the close angle stage. So the first one is the pre-rubeosis stage, which is very commonly seen in diabetic retinopathy patient. The risk is in rubeosis iridis is greatly increased when arteriolar or capillary non-perfusion is present and after vitrectomy or lensectomy. In fluorescein angiography of the iris, we can see there is peripapillary leakage of the fluorescein, and it is important to pay close attention to the pupillary margin of the iris as the neovascularization is first seen here. Another most common cause is the CRVO. In pre-rubeosis iridis stage, it is seen that it develops hypotony because of the blockage of the vessel. The exact mechanism is not known. The fluorescein angiography reveals abnormal leaking vessels in virtually all eyes with extensive retinal capillary closure after CRVO. Aqueous protein and cell concentration shows severity in laser flare cell meter. In relative apparent pupillary defect, there is increased risk of neovascularization seen. Most diagnostic finding is electroretinogram. In ERG, B wave implicit time delay is seen, and there is reduced B wave and A wave amplitude ratio. And blood flow velocity shows color Doppler imaging can be done. Pre-glaucoma stage, in this rubeosis iridis is seen. It is characterized by normal IOP unless pre-existing COAG is present. In slit lamp, we can see dilated tufts of pre-existing capillaries and fine randomly oriented vessels on the surface of the iris near the pupillary margin are seen. Leakage of the fluorescein is seen from the new vessels. Peripapillary iris, the first site to be seen with neovascularization. And on gonioscopy, angle vascularization, single vascular tracts crossing the ciliary body band and scleral spur and arborizing on the trabecular meshwork can be seen. In the open angle glaucoma stage, doesn't invariably follow the development of rubeosis iridis. It may resolve spontaneously in diabetic retinopathy cases with incidence of 13 to 41%. CRVO has higher incidence, typically occurs 8 to 15 weeks after the vascular occlusive event. And it is also, it has been called as 90-day glaucoma. Rubeosis iridis is more florid in this stage. In gonioscopy, AC angle is open, but neovascularization may be intense. On histopathological features, the hallmark is the fibrovascular membrane that covers the AC angle and anterior surface of the iris and may even extend to the posterior iris. Glaucoma occurs due to obstruction of the trabecular meshwork by the fibrovascular membrane with variable contribution from the inflammation and hemorrhage. Space between the trabecular beams were lined by a single layer of vascular endothelium and were filled with RBCs. Angle closure glaucoma stage. Stroma of the iris has been flattened with a smooth glistening appearance. Ectropion uvea is frequently present. Iris is dilated and pulled anteriorly from the lens. Contracture leads to formation of peripheral anterior synechiae. In the open angle glaucoma stage, histopathological features show alteration of the angle from the contracture of the tissue overlying this surface, these structures. Tissue contraction, a superficial layer of myofibroblasts, that is fibroblast cells with smooth muscle differentiation can be seen. Then coming to the diagnosis part, history taking in which patients with diabetes mellitus, hypertension, arteriosclerosis, and a previous history of vision loss indicative of CRVO or CRAO or retinal detachment is considered risk factor. Gonioscopy is to be done to see the vascularization of the angles. Fluorescein angiography of the iris can be done. Peripheral sweeps and wide field angiography is done to see peripheral retinal capillary non-perfusion and posterior segment neovascularization. On electroretinography, B wave to A wave amplitude ratio is to be measured. Coming to the treatment part,
the previous photo, can you describe the photo?
So this is the picture of gonioscopy finding of the superior angle, where we can see the patient is actually going into angle closure glaucoma stage, but here you can see neovascularization of the angle. Few vessels can be seen in the.
Can you enlarge the size of the photo? This was taken yesterday?
Yes, sir.
It's not very clear, but yes, we can see the peripheral anterior synechiae there.
Yes, sir.
Okay, this was a case of neovascular glaucoma?
Yes, sir.
Go ahead.
Coming to the treatment part, PRP is the first line of therapy in all cases of neovascular glaucoma. In the open angle glaucoma stage and early angle closure glaucoma stage, PRP may reverse or mitigate the IOP elevation. Pan-retinal cryotherapy is advised when there is cloudy media and when complete PRP fails to halt the progression of neovascularization. The glaucoma filtering surgery in NVG cases, it prevents the pressure-induced injury to the optic nerve. It improves vascular perfusion. And before surgery, PRP is done to reduce or eliminate the stimulus for angiogenesis. By allowing the maximal amount of time between PRP and glaucoma surgery, the risk of intraoperative and postoperative bleeding and severe intraocular inflammation is reduced. Younger age, that is less than 50 years, and type 1 diabetic patients are significant risk factors for early surgical failures. Non-invasive techniques are advised to achieve patient comfort if the eye has no visual potential. So topical corticosteroids and cycloplegics are advised to relieve ocular discomfort. Topical beta-adrenergic blockers and alpha-adrenergic agonists and carbonic anhydrase inhibitors are advised to reduce aqueous production. Miotics are avoided as they may aggravate the intraocular inflammation and pain. And once the angle is closed, along with medical therapy, surgical intervention is needed. Cyclocryotherapy is advised for elevated IOP. Cyclodestructive modalities most commonly used is the diode laser cyclophotocoagulation of the ciliary body. In this, a transscleral probe is it is given transsclerally. 810 nanometer diode laser is used with a semi-disposable G probe. The pain and inflammation of this procedure is typically less than that seen with prior more destructive versions. In painful eyes with poor visual potential, cycloablation, retrobulbar alcohol injection, and enucleation can be advised. In nutshell, pan-retinal photocoagulation, ablation of the peripheral retina with laser, argon can also be used, which is the first line of therapy. It is significant to reduce.
Argon laser is no more available, so don't use this.
Yeah.
We use green laser, which is double frequency NT.
Yes, sir. It is significant to reduce or eliminate anterior segment neovascularization. The mechanism is uncertain, but related to decreasing the retinal oxygen demand. It reduces the stimulus for release of angiogenic factors and may reduce the hypoxia in the anterior ocular segment, indicated in all cases of rubeosis iridis, and photocoagulation should be performed in pre-rubeosis stage. Panretinal cryotherapy in case of cloudy media can be done. Then anti-VGF agents, bevacizumab 1.25 milligrams in the vitreous cavity and 1 to 1.25 mg in anterior chamber can be given. It seems to show significant regression of a concomitant reduction in IOP, and it is important to proceed with PRP as soon as practical to help prevent recurrent neovascularization. The glaucoma surgical procedure, cyclodestructive surgery, transscleral NDR, cyclophotocoagulation, and diode laser cyclophotocoagulation can be advised. Filtering surgeries, they are rarely successful, and glaucoma drainage device surgeries encouraging results with adjuvant bevacizumab are seen. Endoscopic cyclophotocoagulation, silicone oil injection, IV injection of crystalline triamcinolone or acetonide can be given. So the best way to treat NVG is to prevent it from occurring in the first place. Thank you.
So can you tell me stage-specific treatment? In pre-rubeosis stage, what is the treatment of choice?
So pre-rubeosis stage, we can give PRP can be done.
No, you have to do PRP. So you have to look for any risk factors, like in diabetics. If patient has very severe NPDR and there are higher, non-perfusion areas, then we have to go ahead with panretinal photocoagulation.
Yes.
In rubeosis stage?
In rubeosis stage, PRP along with bevacizumab can be done.
Okay, so we are talking about diabetic here, but there are other causes of neovascularization also, like your long-standing retinal detachment, chronic uveitis. So you have to find out the cause.
Yes, sir. Treat the cause.
Sometimes there can be a malignancy also. So if there is a neovascularization where media is hazy, then you have to go do B scan, ultrasound, to check if there is any mass lesion present behind.
Yes.
That has to be ruled out. Then for rubeosis stage also, you have to, most common cause is diabetes again, and then other causes like CRVO. So in CRVO, basically for CRVO per se, there is no use of any laser photocoagulation. But if NVI starts appearing, then we may have to either go for a anti-VGF injection, which may be frequently required, or we can do PRP along with anti-VGF as per requirement. But if the disease process goes to neovascular glaucoma where IOP rises, then in that case we have to, apart from doing the preventive measures, so neovascular glaucoma, still you have to do panretinal photocoagulation if it is visible. If media is hazy, then we may have to use anti-VEGF, or still if it is not clearing, then anti-retinal cryo can be done. So we have to do preventive measures even in case of neovascular glaucoma, because that will reduce the chance of progression and may regress the new vessels also. And then if IOP is still remaining high, then we have to go ahead with, you have to decide whether we have to go ahead with filtration surgery. So filtration surgery, the risk of failure is little higher. If filtration surgery has to be done, then it has to be done in adjuvant with anti-VEGF treatment to reduce the neovascularization, or glaucoma drainage devices can be done. In end stage, we have to try cyclophotocoagulation. So even in advanced cases of NVG where still some visual potential is left, we can think of doing graded cyclophotocoagulation if the chance of failure of filtration or tube is high, or the patient is not ready for any surgical intervention. Then we can go ahead with graded diode cyclophotocoagulation, where we can do maybe 90° to 180 first, and then increase it after 3 months if the IOP still remains high. So
Yes.
we have to manage it that way. And so in the last stage, if visual potential is not there, then for pain relief, still we have to control the IOP. And by either most commonly we use the diode laser cyclophotocoagulation to reduce the IOP and make the patient comfortable. And steroids and cycloplegics topically are useful for inflamed eye to reduce the pain of the patient. And common mistake done is that patients with NVG, when they come to OPD, sometimes IV mannitol is given, but IV mannitol is used for acute angle closure glaucomas or acute raised pressure. So NVG, the pressure will remain high. So mannitol will have effect only for 2-3 hours, and again the IOP will rise. So you can shift the patient on oral this thing like Dimox, and then topical anti-glaucoma drugs. So IV mannitol is not generally used if the patient has NVG. You can use, but the effect is very short. So it's better that we shift to something which can be taken long term.
Yes, sir.
Any other questions or doubts? Other fellows?
Sir, I had a doubt.
Yeah.
Sir, suppose the patient is of CRVO and rubeosis iridis is seen, but there is no elevation in IOP. So initial management, should we give anti-VEGF till the hemorrhages subside, because PRP immediately will not be possible because of the hemorrhages. So initially anti-VEGF will take for some time PRP, or at the same time PRP.
So start with anti-VEGF, and CRVO patient will require monthly anti-VEGF.
Okay.
Generally with anti-VEGF, the neovascularization will regress. Then you can take a call whether you want to do PRP or you want to continue anti-VEGF for that patient. So PRP has an advantage that the requirement of anti-VEGF will reduce and neovascularization will reduce. But there is a chance that vision will further deteriorate. So if it is a one-eyed patient, then I would prefer that I will keep the patient on monthly anti-VEGF. So whatever vision is there may be preserved for long term. But if other eye is okay, and this eye I just want the patient to be relieved from neovascular glaucoma, I will go ahead with PRP after giving anti-VEGF.
Okay.
And other option is then after PRP, if still IOP is high, then we have to go ahead with the IOP lowering surgery.
Sir, one more doubt. Sir, in rubeosis iridis secondary to CRAO, they are faster progressing as compared to CRV. Is it correct, sir?
Yeah, correct.
So in that cases, how should we keep the follow-up for CRAO patients? Because many cases we just explain to them that visual prognosis is poor and they don't turn up again. So, I mean, how often to call them?
So CRAO, the glaucoma, sensitive glaucoma developing quickly is more. And so we just like CRVO, we have to follow them up every month. Of course, visual prognosis is guarded because in CRAO there is nothing much we can do. Even anti-VEGFs are not useful for improving vision. But we have to follow them up so that if there is, in case neovascularization starts, we have to do PRP.
So a follow-up should be like after a month or in 15 days? How
Monthly.
Okay.
Though the neovascularization develops rapidly, it is not very common. Like all patients will not develop neovascularization. So monthly is fine.
Sir, I had a doubt. We advise PRP before the filtering surgery. So how much gap should be given, or like what is the basis when should the patient be taken up for glaucoma surgery after PRP is done?
PRP's effect will take a long time, almost 2-3 months. So along with PRP, we have to give anti-VEGF if we are considering the glaucoma surgery. So after anti-VEGF, we can take up the patient in a week.
Okay.
So it's very important in diabetic patients to look for the iris very closely. So you should use a good slit lamp, high magnification, and look for the iris. And particularly CRVO follow-ups, the two things which we have to look for, or three things post CRVO follow-up, is that one is OCT for looking for edema if it is again coming back after initial anti-VEGF injection. Second is intraocular pressure, and third thing we have to look for is any presence of NVI. So if NVI start developing, we have to start thinking of going ahead with photocoagulation, retinal lasers.
Yes.
Okay, any other questions?
That's all.
Okay, chalo, I will end the meeting.
Yes.
Thank you.
Thank you.